thank you everybody for joining us tonight, and a special thank you to Prof. Henriette Farkas, who's joined us all the way from Hungary to talk to us tonight. This is one of the topics that we as an organisation have the most queries about, especially in regards to what medications we can take, what are triggers for us. So please, if you have any questions, please pop them into the chat box and we'll try and address as many of them as we can at the end of our talk. Thanks, everyone.
Thanks so much, Janice. And it's my pleasure to introduce Henriette Farkas to you. Professor Farkas is from Hungary, Budapest particularly, the Semmelweis University. And Dr. Farkas has been a fixture on the scene of hereditary angioedema, education, training, and research for a very long time, and has been involved in all of the seminal documents and position statements from international organizations. And she has a special interest in this particular issue relating to hormonal and other changes and really the broader aspect of women in hereditary angioedema. She's also done some incredible research on laryngeal edema, and we're very fortunate also that she's been a PI, national and international PI on some of the important new therapies for HAE as well. So we're very happy to have you speaking to us today on what is one of your favorite topics, and we're looking forward to this discussion today. Thank you so much, Prof. Farkas.
Thank you very much, Professor Michael Levin, for this kind introduction, and warm welcome, everyone. Thank you for joining the webinar. Many thanks to the organizers, especially Professor Johnny Peter and Janice Freedom for inviting me. I really appreciate their huge effort in the patient's interest. Next, please. Next slide, please. Here are my disclosures. Next. It would have been nice to meet in person because I like Africa. I have visited in your beautiful country. I attended the ACE conference of the Federation of African Immunological Societies in Durban in 2012. At that time, I was one of the invited speakers for the first HAE workshop. My topic was HAE in women. Interestingly, Professor Peter selected the same topic for discussion during this webinar. Next, please. I had the opportunity to spend a few days in your wonderful country, and I enjoyed meeting with people and cute children, and I enjoyed fabulous African nature. During our trip in Luluve Game Reserve was a special event. I took a picture of it, you can see here. The president of HAE International, Henrik Boysen, first administered icatibant to his wife, who had a very severe abdominal attack. And this administration was in the middle of Luluve Game Reserve. And we were very happy because after administration of icatibant, his wife's symptoms resolved within 15 minutes, and we could continue our trip. Next, please. Next slide, please. I live in Budapest, which is the capital of Hungary. Hungary is a small country in the middle of Europe with 10 million inhabitants. Next, please. I have been working at the Semmelweis University, Budapest, that is one of the centers of expertise for rare diseases. Hungarian ACARE Centre, that is one of members of ACARE, was established 30 years ago. Next, please. Because we have the only angioedema center in Hungary, patients with different types of angioedema are referred to our Center for Differential Diagnostics. As you can see on this graph, the number of patients diagnosed with HAE increases continuously. Currently, more than 200 patients with HAE are managed at our center. Next, please. I am pleased and honored to talk about women with HAE, and it will be based on my more than 40 years clinical experience and based on recommendations of international guidelines. As well known that HAE is an autosomal dominant inherited disease and affects males and females equally in HAE with C1 inhibitor deficiency. In HAE with normal C1 inhibitor, the penetrance is incomplete, therefore females are more frequently affected. Women have more frequent and more severe HAE symptoms than men. Next, please. What is the reason of this observation? Female sex hormones play an important role in the onset of HAE and the frequency of HAE attacks. These hormones affect the synthesis of many proteins which are important in generation of radical. Estrogen-containing oral contraceptives, menstruation, pregnancy, and hormone replacement therapy are important trigger factors in HAE with C1 inhibitor deficiency and in HAE with factor 12 mutation. Next, please. All approved medicinal products can be used for treatment of HAE in female patients, such as intravenous plasma-derived C1 inhibitor for acute treatment, short and long-term prophylaxis, subcutaneous plasma-derived C1 inhibitor for long-term prophylaxis, recombinant human C1 inhibitor. It can be used intravenously for acute treatment, subcutaneous icatibant and ecallantine for acute treatment, lanadelumab administered subcutaneously for long-term prophylaxis, berotralstat orally administered for long-term prophylaxis. These drugs are first-line treatment options. Attenuated androgens such as danazol, stanozolol, and antifibrinolytics, tranexamic acid, are second-line therapies for long-term prophylaxis. Solvent detergent and fresh frozen plasma may be administered when these therapies are not available. When we use attenuated androgens or recommend attenuated androgens for female patients, we should consider several side effects, and these drugs can be used critically. Next, please. This slide shows the side effects of danazol and stanozolol, such as hepatotoxicity, polycythemia, hyperlipidemia, but virilizing effects is the primary adverse reaction of this drug. Next, please. I collected the virilizing androgen-like effects of these drugs. Hirsutism and menstrual disturbance are the main virilizing side effects. In some countries, only these drugs are available for long-term prophylaxis. We use these drugs for long-term prophylaxis 20 years ago, and my experience that the adverse effects can be minimized by administering the lowest effective dose, and the patient should be monitored carefully. Next, please. This is a very, very nice figure, very interesting. It shows the sex hormone changes over the life cycle. Symptoms usually worsen during puberty. You can see that estrogen levels are increased. Menstruation and ovulation may provoke attacks. In elder age, symptoms during menopause, symptoms may improve or worsen. So we should consider this observation when we treat these patients. The profile of sex hormones changes during pregnancy. Estrogen level increases continuously. Next, please. A lot of working groups from different countries have been published their clinical experiences on pregnancy in HAE. Next, please. Data have been accumulated from more than 700 pregnancies of more than 300 patients. Next, please. Different guidelines summarize recommendations, special guidelines, this one, and general guidelines. The first international consensus and practical guidelines on the management of female patients with HAE was published in 2012. It planned to be updated. General guidelines also contain recommendations on women with HAE. Next, please. What should be considered if the patients with HAE want or do not want a child? Next. The strategy should be created with shared decision making. HAE expert shares information. Patients consider the options, and after discussion, they make a decision together, from family planning to the childbirth. Next, please. The family planning is essential. if the patients don't want to have a baby, the appropriate contraception should be selected. Next, please. Estrogen-containing oral contraceptives should be avoided because these drugs increase frequency of HAE attacks and symptoms are more severe. In some cases, the initial symptoms may occur after introduction of this therapy, especially in case of HAE with factor 12 mutation. Barrier principle protection and progestin-containing oral contraceptives are recommended. Next, please. The fertility rate is the same as in general population. Next. I like to note that attenuated androgens may cause temporary infertility in men, but antifibrinolytics do not impair fertility. Before these interventions, different hormonal therapies are used for ovarian stimulation. These drugs may increase frequency and severity of HAE attacks. Salpingography, artificial insemination, and in vitro fertilization as a procedure may provoke HAE attacks. Therefore, short-term prophylaxis with plasmadiol C1 inhibitor is recommended before these interventions. Next, please. Pre-implantation genetic diagnosis is possible if a mutation is detected in the family. It means that the healthy embryos are selected before implantation. Before these interventions, short-term prophylaxis with plasmadiol C1 inhibitor is recommended. Next, please. Contemplating conception is also recommended. In particular, if the patients use androgens for long-term prophylaxis. Next, please. Attenuated androgens, danazol and stanozolol should be discontinued at least 8 weeks before contemplating conception. These drugs can cause irregular menstruation, therefore timely recognition of pregnancy should be ensured by performing pregnancy tests. Androgens may increase the risk of masculinization of the female fetus as well. Next, please. Next. The genetic counseling is essential. Next, please. The patient should be informed that HAE is an autosomal dominant inherited disease. It means that 50% of the chance of the offspring to inherit this disease. Poor correlation have been observed between the type of mutation and clinical manifestation of HAE. Next, please. What shall we consider during pregnancy in patients with HAE? Next. Consultation with obstetricians is essential. Prenatal diagnosis is possible. However, it is difficult to give an advice on terminating a pregnancy because the symptoms or HAE is unpredictable. We cannot give advice. Next, please. How is the frequency of HAE attacks during pregnancy? Next. Next. Pregnancy can result in worsening, improvement, or no change in the HAE clinical course. Each pregnancy may follow a different course, and 73% of pregnancies have similar course. I have some patients who want to become pregnant many times because they didn't have any symptoms with their pregnancy, but the others had unfortunately frequent attacks. Next, please. What is the location of HAE attacks during pregnancy? Next. We observed, as you can see on this graph, that abdominal attacks occur more frequently during pregnancy than before pregnancy. We suppose that it's caused by progressive enlargement of womb and fetal movement. These can trigger HAE attack during pregnancy. Next, please. Pregnancy has 3 trimesters. Next, please. All 3 trimesters may be involved. The most difficult period is the first trimester, but symptoms may occur frequently during second and third trimesters as well. I'd like to share with you some interesting observation. A number of HAE attacks increase in women who have identified mechanical trauma as a provoking factor before pregnancy, and women who had more symptoms during their menstrual period usually have more HAE attacks during pregnancy, and women with early initial onset of symptoms exhibit greater number of attacks than those with a later onset. The presence of fetus with HAE can increase the number of HAE attacks. Next, please. Unfortunately, the treatment options during pregnancy are limited. Next, please. Plasma-derived C1 inhibitor is the first-line treatment during pregnancy, and it is the only treatment, only recommended treatment. We have experience with intravenous plasma-derived C1 inhibitor for acute treatment, short and long-term prophylaxis during pregnancy. Limited information are available on subcutaneous administration of this drug. Next, please. I'd like to present you a case. The patient took danazol and had 5 miscarriages. With appropriate family planning and adequate treatment It means the patient were treated with plasma-derived C1 inhibitor before, during, and after pregnancy due to breastfeeding, and with close cooperation with obstetrician. Sorry, back please. Eventually, she had 2 successful pregnancies. George and Francis are healthy, and they didn't inherit C1 inhibitor deficiency. Next, please. The other approved therapies can be used, however, we have limited experience with these drugs. So plasma-derived C1 inhibitor is recommended during pregnancy. Only case reports and some case studies have been published on treatment of HAE with these therapies. Next, please. Antifibrinolytics, the tranexamic acid, can be used for long-term prophylaxis during pregnancy, but attenuated androgens, stanozolol, should be stopped because these drugs are contraindicated during pregnancy. As I said, androgens may increase the risk of masculinization of fetus. Solvent detergent and fresh frozen plasma can be used during pregnancy if plasma-derived C1 inhibitor is not available. Next, please. So I'd like to emphasize again that during pregnancy, plasma-derived C1 inhibitor is the only safe first-line treatment. Next, please. During delivery, consultations with obstetrician, pediatrician, and anesthesiologist are recommended. Next, please. Delivery should be managed in hospital setting. Interestingly, labor and vaginal delivery is other huge mechanical trauma, but only rarely induces HAE attack. Therefore, short-term prophylaxis is not necessary before uncomplicated delivery, but plasma-derived C1 inhibitor should be immediately available. The rate of spontaneous abortion is the same as in general population, is approximately 12% population, 10 to 20%. Next, please. Complicated, in some cases, we should take into account that the delivery can be complicated. Next, please. Before complicated delivery, short-term prophylaxis is recommended with plasma-derived C1 inhibitor. If it is not available, frozen plasma can be administered before surgical abortion, forceps delivery or vacuum extraction, and cesarean section. Epidural anesthesia is recommended because intubation itself may provoke laryngeal attack. Next, please. My favorite topic is a newborn screening. Next, please. The first question is whether or not the newborn has inherited HAE. Next, please. All asymptomatic newborn infants with positive family history should be screened. At our center, the screening is performed from peripheral blood or umbilical cord blood by complement testing. Complement test should be repeated after 1 year of age because under the age of 1 year, complement components and C1 inhibitor levels can be decreased in healthy subjects as well. Genetic testing can be done from umbilical cord blood, peripheral blood, and buccal cells as well, if mutation has been detected in the family. We introduce this method with umbilical cord blood and buccal cells investigation by genetic testing, and within a couple of days, the diagnosis can be established. If we know the diagnosis, all newborns should be supplied with plasma-derived C1 inhibitor. However, in our practice, all symptom-free newborns with positive family history are considered to have C1 inhibitor deficiency until the diagnosis is established, and all of them without the results of complement testing or genetic testing are supplied with plasma-derived C1 inhibitor. Next, please. The patient should be carefully monitored during postpartum period because HAE attacks may occur more frequently or may occur within 48 hours, the postpartum period. During lactation, the frequency of HAE attacks may increase. Both postpartum period and during lactation, plasma-derived C1 inhibitor is the only first-line therapy based on recommendation of guidelines and based on clinical experience. Next, please. In a summary, with education, with appropriate family planning, with close monitoring by multidisciplinary team, and using appropriate treatment, the women with HAE can live a normal life and have children like healthy women. Next, please. I would like to give you warm regards of Hungarian team. Thank you very much for your kind attention, and I think the floor is open for your questions. I cannot hear you.
Thank you so much for amazing talk, Professor Farkas. And I think there were a couple of questions in the chat. Tamsin, is there something you want to highlight there? And Johnny, can you join us?
Okay.
Hi, I'm just looking through them. I haven't had a chance to because I was looking at the shared screen. I would like to know if there is a link between HAE and breast cancer, lumps in the breast. I don't think so.
conflicting data are available on androgen effects and breast cancers. So the prevalence of breast cancer among HAE patients is the same as in general population, but we should consider the treatment. Attenuated androgens danazol are not recommended in this condition, and maybe other types of therapy should be selected for treatment of these patients.
Johnny, I see the questions in the chat are quite complicated.
Yes.
Would it be possible for you to take a look at them and just pick up the theme or summarize it in any way? The very simple question are any of our local labs able to look for the genetic mutation? But the other questions are quite long, so if you could look through them and maybe...
Okay, so it is a difficult question. As I mentioned, that tranexamic acid can be used for long-term prophylaxis in those cases when the frequency of attacks increased during pregnancy. But these drugs show limited efficacy sometimes and may increase the risk of thromboembolic event. I think regular administration of plasma-derived, it is not available, fresh frozen plasma or solvent detergent plasma can be used because abdominal attacks may impact the development of fetus. So we should treat the patient by prophylaxis, and unfortunately only only human fresh frozen plasma or solvent detergent plasma is recommended. It is very sad situation that the patient didn't have appropriate treatment, but I know that in some places in the world the situation is similar. So finally, in conclusion, fresh frozen plasma can be used.
Yeah, I think that, thanks, Henriette, and hello, hi, thanks. It's
Hi.
So great to have you. I think there's some questions specifically coming in here from colleagues that are looking after a patient now in Durban in quite a difficult situation in the state sector. So, we have the difficulty is that, as you correctly saying, when there's nothing else available, fresh frozen plasma treatment is utilized, and I think that they're planning for elective Caesar, and I think that you just need to cover with FFP for that delivery perspective. I think that we need to look at something. This is more of an administrative issue that we've been discussing for some time. Is now that we have a Cataband registered in South Africa, we need to work to get it accessed properly everywhere. So and at the moment it's individually dependent on each province, so within the state sector, so it's not that easy to do, and so we have tried to work on that ability in the context of KZN. I think that is definitely, this patient is highlighting that need. And we actually we've now submitted a series, because we've got 3 patients here with off-label use of icatibant during pregnancy for several attacks without any problems for baby or mother. And so I think that certainly we would be in favor, given the slow onset of action of FFP, that if we can get availability to icatibant, certainly outside of the first trimester, where we might be a bit more cautious, but certainly later on in pregnancy, we'd be quite keen to utilize that. I know in the past, in 1 or 2 patients in the private sector, Professor Potter has accessed on a Section 21 basis, has accessed Berinert. So we have actually at some point accessed plasma-derived C1. But so we have the problem that's difficult, which is both a kind of access of less resource areas within the country. But that's something that I think we need to sort out kind of more effectively. That's an access issue rather than necessarily an individual management issue. So I wanted to ask a question here. I think that's coming through. Which monoclonals available locally and how to motivate for state patients? Yes, exactly. That family we know about. And Prashini, I think we need to get together to strategize, because I've been working with Savannah. We've tried to see whether the Albert Lutuli pharmacy can bring it in. It hasn't been straightforward, but that's actually what we need to do. There's reference being made to a province in South Africa, Henriette, where there's a family that's actually been published by a colleague, Sipho Nchalanchali, published about this large Zulu kindred that has multiple family members affected. And you're right, that hasn't been a very good story, and I think we need to do better. So I think thanks for raising that. I'm not aware. So there's another question, Henriette. Are you aware of anything related to tranexamic acid causing piles? I've never come across that. So I don't think that's something that I've noticed, unless anybody else has. Henriette, have you come across with that? Any other clotting risk or risk for?
Only some patients were treated with tranexamic acid. One patient during pregnancy, and we didn't observe any clotting problems during this treatment. So when we start tranexamic acid, we check the thrombophilic parameters. The thrombophilic panel is performed before starting.
And did you find that, were there any patients with that panel that you screened out of using tranexamic acid? If people have...
Yes, all patients are screened for coagulation disorders before starting tranexamic acid.
Okay.
And ask the family history. Is there any family members with venous thrombosis or embolic events, or the patient that maybe had similar events in the past. So I think we should consider this, but we didn't experience any side effects during tranexamic acid treatment.
Yeah, we haven't had ready access to those thrombophilia panels, but we've used just family history, any evidence genetically of an increased thrombophilia as a sort of pre-screening. But we haven't used a more detailed thrombophilia panel. That's quite interesting. There's another question here from Prashini about fresh freeze-dried plasma versus fresh frozen plasma. This is an interesting question, Henriette, that again relates to access in certain areas that can't access a blood bank. They have, there's freeze-dried plasma available, and we have used that. So we've got some experience with freeze-dried plasma. So if that's your only option, that would be what we would choose to use if we were in that situation, and definitely in some of the West Coast cities outside of Cape Town, where people have been far away from care, we've had to use that, and we've sorted that out, and they've been effective. The only issue with it that we chatted to our national, the National Bioproducts Institute and also the blood bank about it, is actually the amount of C1 inhibitor and the stability. And it actually varies quite a bit within fresh frozen plasma, but also even more potentially in freeze-dried plasma. So what we've always advised people is that, airway protection, particularly for laryngeal attacks, is the main focus, and that should not be compromised. So primarily somebody should be in an ER setting to do that. If freeze-dried plasma are the only option, that would be utilized. We should try that. If preference should be given to freeze-frozen plasma if that's available. So that would be the kind of our approach. And then the other thing we do is if we don't see any response within 4 to 6 hours of the freeze-dried plasma, we would recommend moving to a place for fresh frozen plasma or potentially other icatibant therapy. And that would depend, obviously, of protecting the airway as the number one kind of survival safety mechanism. I think I'm not sure who's put this other question is, but around Janice, this is a question for you and maybe Mike as well. A list of doctors in Gauteng who are looking after HAE. So I think that's something we should try to address if we haven't.
Yes,
I mean,
Yeah,
so I see Mark has answered that there. There is a list on the AFSA website. You can just filter for HAE and the area for interest. I unfortunately can't see from my side who that question came from, but I think it's available on the AFSA site.
Henriette, this is a good question from Prashini as well. Is if the patient was using attenuated androgens and they, didn't know they were pregnant, and so have used them into the first trimester, would you recommend a close definition scan for fetal anomalies?
I had the only patient who used androgens during the first trimester in the past. We didn't do any screen for fetal abnormalities, but I think we should recommend this because danazol across placenta and may cause teratogen effect. So
yes,
if it is possible, I think it is recommended.
I would agree with that. I mean, we've had some patients in our Cape Town clinic, and all of our patients with HAE get sort of tertiary level obstetric care, and part of that we would recommend as detailed a possible scan as is available. And in our tertiary center at Chryskea, we can get definitely a level 3 scan, and if that's possible, Prashini, I would recommend that.
A good question.
This is another question from a patient, Henriette, saying that her stomach during attacks swells very badly, that she looks like she's pregnant.
Yeah.
I think the simple answer to that, Michaela, is that if you have any you can have abdominal wall swelling and you can have intra-abdominal small bowel swelling, and that swelling takes space. Literally, there is more fluid. And so it's quite possible that your stomach swells up and during that time and can look like you're pregnant. So I think that relates to the mechanism itself of angioedema in either the abdominal wall or the intestines.
But
Go ahead.
So by abdominal ultrasound can detect free peritoneal fluid, ascites, and bowel edema. So I suggest you to ask abdominal ultrasound during your abdominal attack, and you can see by yourself edematous bowel and fluid in the abdominal cavity. It is the reason that you feel like a pregnant. You back.
Exactly. Tamsin, did I miss some questions? I know there was that.
Sorry, I think is it just Winona's question that we didn't answer?
I can't. I think because I joined a bit late.
Okay, it says
I don't see.
she says my mother was taking blood pressure tablets containing perindoperil argentine. This is going to be all wrong, and amlodipine, whatever, which significantly decreased her HAE attacks, but she unfortunately showed allergic side effects to the tablets. As soon as she stopped having them, the amount and severity of her attacks increased. Is there a relationship between HAE and blood pressure medication?
Yeah, Henriette, this was a question that was posed by a patient on the group about her mother. And essentially, what's interesting is that she was making the comment that she was on an ACE inhibitor and a calcium channel blocker, and actually felt that there was some improvement in her HAE attacks, and that due to side effects related, she's saying in the message, to allergy, then she kind of stopped the meds, and then her attack frequency has increased. I wondered what your comment was on that.
So, based on this observation that ACE inhibitors may provoke or initiate or aggravate HAE symptoms, therefore, at our center, after establishing the diagnosis, we provide the patient with written information about the treatment of hypertension. It means that we ask the general practitioners, or we advise them that for HAE patients, ACE inhibitors as antihypertensive drugs are contraindicated or not recommended. It is slightly.
Yeah, so I mean, I think that's what's interesting about this question is that she shouldn't have been put on perindopril in the first place. We don't recommend ACE inhibitors. She should have been able to use calcium channel blockers. So Winona, it would be interesting to know what you meant by an allergy reaction to the antihypertensives, because perhaps she actually had some other form of swelling or anything to unpack. So that was what was interesting about your question, was just that actually we recommend against ACE inhibitors in the context of an HAE diagnosis. So the one thing to say, though, is that there are several triggers. I mean, patients with stress. I haven't specifically, I don't know if you, Henriette, have heard about hypertension, uncontrolled hypertension increasing attacks. Have you heard of that kind of thing? Uncontrolled medical conditions of various kind increasing attack frequency?
I didn't have a similar experience, but it is a very interesting issue, I think.
Yeah, I also haven't necessarily experienced that, but I mean, certainly some patients have triggers from stress. And, I guess there could be, any uncontrolled medical issue could be a cause of distress and hence potentially drive up frequency. But I just, in your question, one, we can always chat about it at another time with your mom. We would, it's the relationships there are just a bit unusual. Then another question that comes in from Brashini about newborn screening. So in the private sector, we have got access to the Invitae genetic screening that is done through PathCare, and that can look at SERPING1 genes as well as some of the normal C1 genes as well. So we can access genetic screening like that. In the public sector, we've tended to use functional diagnosis. So, well, you can access antigenic C1 and C4 through the National Health Laboratory Service. So the standard health laboratory service, you can access that. In Cape Town, we have now a C1 functional setup in our laboratory, and we've been trying to work with some of the private labs to be able to have people sampled around the country and the sample sent to us. But then, in genetic diagnosis we haven't yet got sort of set up routinely in the public sector. This should be standard practice, but recently the Invitae funding, at least at our tertiary center, got taken away. So that would be something you could explore, Prashini, is a genetic diagnosis through basically the genetics department. That would be the one option to do that. But we don't, at the moment, we would still wait under close observation of family members until the age where we felt that C1 testing would be confirmatory. But obviously we know, given the genetics of the condition, that if there's any sign of attack, we counsel the patients to bring them in. Mike, would you want to add that? Is that how you dealing with the children coming at Red Cross?
Yeah, that's an accurate reflection.
So I think in case of HAE with C1 inhibitor deficiency, complement test is appropriate for establishing the diagnosis. But in case of HAE with normal C1 inhibitor function, genetic test is essential.
Yeah.
At our lab, a genetic test of factor 12 gene and plasminogen gene are available. These are the most common causes of development of HAE with normal C1 inhibitor. So we focus on these two genes, but it would be nice if we could check all involved genes in case of HAE with normal C1 inhibitor function.
Any more questions, Tamsin, we've missed there?
No, not that I can see. Looks good so far. So if there are any more.
There's a question here. Do we know what the most common triggers are?
In female patients, the most common trigger in female patients, I think the menstruation and puberty period, estrogen-containing oral contraceptives. Menstruation is one of the most common trigger.
Okay, I think we've wrapped up all our questions. Thank you, everybody. Thanks to Prof. Farkas. Thank you very much for making the time to be with us tonight. And thank you, everybody else, for being here with us.
Thanks, everyone. Thank you, Henriette. Nice to see you.
Thank you so much.
Thanks,
See you
Mike.
soon
Thanks,
somewhere. Thank you very much.
Thanks, Johnny. Thanks, Mark.
Thanks.
See you all.
Okay.
Come here.